There we are. I'm going to discuss with you something about the insonation of the ductus venosus and briefly how you use it. We have discussed a lot the practical use of it already today. And then I will use most of my talk in discussing rather the liver circulation afterwards. And you might understand why it's like this. But first of all, if you're going to examine the ductus venosus, many of you will use the common insonation that you do transection of the abdominal wall, fetal abdomen. If you then make it more oblique, then you are more likely to get along the umbilical vein and have the first part of the ductus venosus. And you will end up in a picture like this. But if you look at this, then you'll see that if you send in the insonation angle like this, then you are still at some 30-40 degrees. So you adjust this by taking your, if I can get it, by taking your insonation a bit further to this side where the back is, and then you might get it in this to improve slightly. This is not a bad insonation, and you might get a really good recording. So once we got to this, I would just like to ask you the first question, as we've started doing today. And this question is concerning the DV assessment. Wave, form, and pulsatility is important, not the accurate insonation and absolute velocities. Do you agree? So if you have the waveform, you don't need the angle correction. You just have the waveform, and the pulsation you can assess by the A wave. Then absolute velocities and insonation isn't that important. Okay, we continue then, and we'll answer the question later on. You can also do the insonation in a sagittal plane, which means along the abdomen. And if you can insonate from the front, then you have no ribs and no spine, and then you preferably insonate from below here to get the angle as good as possible. That's what you have here. This umbilical vein, the ductus venosus comes here, and you see that the insonation now will still be at some angle of the ductus venosus, but now you can control it. So if you move this then further down, you can get an insonation in this direction, which would be perfect. So then you have the color on, and then is the question, is this okay? Or this, or this, or this? All of them are okay. And the reason for that is that the ductus venosus is not necessarily a straight line, but curves until the ductus venosus points at something like 50 degrees towards the IVC. So from going in this direction, it starts out and then it curves up. If you angle correct on this point, you have quite a risk of overcorrecting. So I would prefer repeat if you are not sure that you have the right insonation, repeat it and take the best you have. The other possibility is going from the opposite side if the baby turns the back towards you. From a classical point of view, that should be the very best, because then you have the velocity towards you, which is usually the better signal than which goes away from you. But in this situation, you can see maybe the IVC, the atrium, and you have now run all the way up the spine on the level of the heart, or even be above it, and then you're looking down here because you expect it to come here. And then you put on what you don't see, the color, and you get a perfect insonation here. If you now insonate here, it will be just nothing to correct. And then you get it. So that's what you use then. And then you get the pulsatility. Now I would like to take you to a different place. And that is what this slide shows. Because we had tradition for thinking that since oxygen to the heart and the brain is so important, how much goes through the ductus venosus? Well, from fetal sheep and from other experiments, we learned that it was roughly 50%. But they were experiments, and the circulation in the liver is very delicate. So once we get into the humans, then we see that actually it is not 50% going here, but it's at 30 weeks, maybe 20, but with some variation. At mid-gestation, 30. So 70, 80% goes to the liver. So when you have the placental resources, which you find so important, including the oxygen, you filter 80% of this blood through the liver. The first you do. There is an experiment done by Chirikov in Hamburg for some years ago, where he obliterated the ductus venosus in sheep, so that he forced all the blood to go through the liver, perfusing the liver. It ended up with producing more IGF in the liver, and these IGFs induced more proliferation in all the rest of the organs. It's because the liver is the metabolic brain of the fetus. You need a decent placenta, good circulation, but once you have that, it's the liver that reads this. So if you have a good perfusion of the liver knows that the resources are there, expands, proliferates, produces IGFs, and details out the growth of the fetus. You can go the other way around. If you have no circulation to the liver, you will have no baby. None of us have ever experienced agenesis of the liver, because it's agenesis of the fetus. So this was what the story I told you. There is a proliferation in the heart, cell proliferation, the skeletal muscle, the kidney, and so on, not in the placenta. So that is the background why liver is quite interesting. The liver is perfused mainly by the umbilical vein, but it also gets blood from the portal vein, of course, and it gets blood from the hepatic artery, which comes from the celiac trunk here. And this hepatic artery divides in the left and the right, and we prefer to use the left for some reason I can tell you later on. But this is the complicated list of blood flows, areas that is somehow running or ruling the liver circulation, in addition to the splenic artery, which feeds the portal system. Let's see if this works. Okay. This is the conventional thing that you often will see, blood flow into the umbilical vein, the ductus venosus just leaving off, up, and then this goes into the left portal vein. And somewhere here, then the main portal stem will come from the pancreas and the spleen up here and give blood further in here. If you slightly change your position so that you don't see the umbilical vein anymore, but you see the left portion of the portal vein, then you see the stem coming here. So the blood after birth will come up the main stem, distribute to the right and to the left. But in fetal circulation, blood from the umbilical vein will come in this direction. So the left portal branch will have blood going towards the right side, this way. That's what you saw in the previous one. See if we can get it going further. So that's what we see here. The umbilical vein comes, the left portal vein. This is the main portal stem, and all blood goes towards the right side, which means that the right liver will get a mixture of low oxygenated portal vein that comes from the gut and spleen, and high oxygenated blood which comes from the umbilical vein through the left branch here. How much will that be? Well, we looked at that at one stage, and this is the umbilical flow which goes into the liver. You subtract what goes through the ductus venosus. This is just all the venous blood that comes to the liver. So it's 85% from the umbilical vein, and the portal vein is 15-20% towards the end of the pregnancy. So it's a small proportion of portal vein coming to the liver. Umbilical vein flushes the liver, mainly the right side, no, the left side. And that's what we have drawn here. So blood comes from the umbilical vein, perfuses the left side of the liver through the left branch, and then mixes up with what comes from the portal vein, so that this part of the liver, the right side, gets a mixture. Look at this. This is not normal anymore. This is a fetus. You see the stomach here. This is the umbilical vein. The ductus venosus is going off here. This is the left portal vein. The blood should have gone from the umbilical vein down here into the right side. The portal stem comes here, but it's on a slightly different level, so you can't see it. But the red blood here tells you that there is blood going in the opposite direction in the fetus than we would expect. It should have been blood, oxygenated blood going from here down here, and it's the other way around. This is another watershed in the fetus, and the liver circulation is very delicate, perceptive. You can do the Doppler, and you see that it is reversed. This is typical for the left hepatic vein, and it's retrograde, and you can calculate it. And it means that once this goes in this direction, the watershed is shifted towards the left. So if we have a fetus where the blood that comes from the umbilical vein is no longer enough to really feed the huge liver, one of the compensatory mechanisms that the fetus can do is to fill up this with a portal vein. And the more you fill up with a portal vein and the less you have from the umbilical vein, then the oxygenation of the liver will increasingly be like this. And when the fetus is in the situation that it has hypoxia, then it also distends the ductus venosus so that it is increasingly sending blood up through the ductus venosus, less to the liver, and it is more and more deoxygenated in a way. This is a short-term solution, which the fetus has made a priority for the heart and brain, more the heart than the brain actually. And the liver suffers. But the liver is a very adaptive organ and will carry with these signals, this adaptation which it suffers now, will be carried into life later on. If you look at the growth restricted, then you see those growth restricted, they have lower blood flows in the left portal vein, or even reversed, as we see two of them here. So that is another way of monitoring, if you like, fetuses at risk, what we do today. Well, then I come to the situation that you are carrying blood into the umbilical vein here. This blood goes 20% up the ductus venosus, 80% goes through the tissue of the liver, but to perfuse the tissue of the liver, you need a certain pressure here. And this pressure is vital. that is the same as the portocaval pressure gradient. The portocaval pressure gradient drives the blood through the liver and drives the ductus venosus velocity. The higher velocity you have reflects the higher pressure gradient. So if you can measure accurately the blood velocity, absolute velocity, then you can also say something about pressure gradient. So now we are back to this insonation. We got an accurate angle, and we can measure the velocity here. And this velocity is directly connected to pressure through the Bernoulli equation. Let me take an example for you. This is a growth-restricted fetus originally, but it's more than growth-restricted, as you see. There is an ascites. Why? Do you find anything wrong with this liver? Come on. Sorry? Coarse? Small. Exactly. It's small, it's rounded edge, and it's a coarse surface, and a coarse also texture. Why? You look at the ductus venosus. Pulsatility. Is there anything that you would remark? Speak up. The pulsatility is pretty okay, isn't it? It's 22 weeks. If you plot it, we have plotted it repeatedly, and it's very low. It's 40, 45, and that's just what you can manage to have and still keep yourself alive. You don't get down to 20 for a long time unless you're dead. So the pressure is down. And why is that pressure down? The umbilical artery is perfect. The cerebral artery is perfect. But this is not perfect. This is a sagittal view now of the ascites, the liver, the pleural effusion, the bowel. And what is this? That's the hepatic artery. So if you can't keep up pressure in the umbilical or the portal system by the umbilical vein, the portal system, you have to take the next resource, artery. The hepatic artery is not able to substitute what comes from the umbilical vein, but somehow to compensate. It is flowing. In this case, enormous velocities. And if you plot it on the normal ranges, you see the pulsatility is down here, and the absolute velocity is up here at the most. The reason for this is there is something called adenosine, which is vasodilating. Adenosine is produced in the liver sinusoids continuously. The portal system washes this adenosine out. At the moment when you have less portal perfusion, the adenosine concentration increases and it dilates the arteries. That's what you see. And the reason for it all is this. Can anybody make the diagnosis? Shunt. It's an intrahepatic portosystemic shunt. This is the umbilical vein. There is a shunt directly to the median liver vein, and that takes out the pressure, reduces the liver, kills the baby at the end. There are more reasons to have small babies than placental insufficiency. And you should be aware of that and start to search for those rare cases. Some of them you can salvage. This is the portosystemic shunt, and you can have different types of it. So that brings me to a kind of conclusion then, that the liver circulation is a composite one. It gets, of course, from the umbilical vein, it gets from the portal system, which comes from the splanchnic and the spleen. So even the splenic artery is somehow involved in this. And you get it from the hepatic artery, which has also a kind of contribution to it. But since this is such a delicate thing, you can understand that if there are changes instantly, that will adapt to it. So by reading this picture, you can also get an idea of where the baby is going. So I think there's a great future for this. We had this question, waveform and pulsatility is important, not accurate insonation and absolute velocities. That's certainly true if you're going to assess heart function, or if the baby has problems with the placenta and have an increased pulsatility index or impedance in the placenta, then you have cardiac function changes. But if you would like to have things a bit deeper dig a bit deeper into some of your patients, maybe this is the kind of thing you have to train on to get a good recording of the ductus venosus, starting using also absolute velocities. Thank you.